Thank you, Dr. Vaishali and the Endocrine Society of India. I thank Dr. David, Dr. Ameya, Darshana, Suhas, and Jugal for inviting me here. I'm not able to share my screen. Can the host allow me to share my screen? Okay. So I've been practicing actually since 30 years, not 37 years, but that's okay. And as we begin with the ultrasound of thyroid nodules, we must remember that ultrasound has been a foremost imaging modality for the neck, as has been highlighted by Dr. Rakesh and other speakers before me. I just want to start with this slide to make people aware of what we talk about echogenicity when we speak about nodules. So here you see a cross-sectional image of the thyroid lobes, and that's the trachea in the center, the sternocleidomastoid on either side anteriorly, and the carotid artery posteriorly. Now, we use reference points for echogenicity. So the carotid is hypoechoic, that means it is black and it has posterior enhancement, and that is typical of anything that is cystic or is lucent. The sternocleidomastoid muscle here anteriorly is of intermediate echogenicity. It is hypoechoic relative to the thyroid gland, which we consider as isoechoic. So this is normal echoic thyroid gland, which is very similar to other organs in the body, like the liver, etc. And this is sternocleidomastoid is slightly darker, and it is not as dark as the carotid. So carotid echoic, this is hypoechoic, and this is isoechoic. And if you see here in the trachea, there is a white shadow here, which is the cartilage here, which is extremely bright. So that is what we consider as hyperechoic with posterior shadowing. So it shadows, and also because of the air in the trachea, we don't see the lumen, and it shadows completely. So these are the 3 or 4 constant terminologies that we would be using when we talk about thyroid nodules. The advantages, everybody knows that its ultrasound is easily available, non-invasive, no radiation, non-expensive, and can be a portable bedside tool, and it can guide therapeutic and diagnostic interventional procedures. Of course, there are limitations. We cannot talk about thyroid function as you can speak with a nuclear scan, but with color Doppler, we can find out whether a nodule is vascular or non-vascular. So when do we do ultrasound is to confirm the presence of a thyroid nodule when physical examination is equivocal, to, of course, characterize a thyroid nodule and differentiate between benign and malignant. That's the main aim of all imaging modalities. And to differentiate between other extrathyroidal pathologies which can overlap the thyroid. And of course, to look for background changes in the thyroid, to detect post-operative residual or recurrent tumor and metastasis, and to screen for high-risk patients who have high risk of multiple endocrine neoplasias, and finally, as I said earlier, to guide interventional procedures. Now, as Dr. Vaishali mentioned, thyroid nodules have become very common, especially since ultrasound now allows us to see almost about 10 to 40% of individuals have nodules, vis-a-vis on palpation about 4 to 8%, and this increases with age. The malignancy risk is more in the younger and in the older, and of course, if there is a history of familial cancer and neck irradiation. But overall, the prevalence of cancer will be about 10 to 13%, even if there are multiple nodules, and the dominant nodules show cancer in more than 2/3 of the cases. And it's very gratifying to remember that most thyroid nodules in presence of multiple nodules also are benign, and less than 10 to 15% will be malignant. So the benign nodules are usually cysts and pseudocysts, more commonly pseudocysts, which are degenerative cysts, the hyperplastic adenomatoid nodules of the endocrine gland, and the malignant thyroid nodules are papillary carcinoma, which is the most common, and then of course follicular medullary lymphomas, anaplastic, and metastasis. Now, what are the three different modalities that we use with ultrasound? There is also a fourth modality is contrast, but I have not included that here because we have just started doing ultrasound contrast for thyroid nodules. So it's very new. But basically, B mode ultrasound gives us the acoustic information, and that gives us the anatomy. The color Doppler tells us about motion of the RBCs and the vascularity of the lesion. And finally, we have elastography, which we use quite commonly, and you'll see a lot of my images will have elastography, which tells us about the stiffness of the tissues. So all these three components are used. We use high resolution transducers going up to nowadays 20 megahertz in a supine position with the hyperextended neck, and we scan in transverse and longitudinal planes from the base of the mandible to the clavicle. And we use all these three modalities. Now, just to begin again, that's the longitudinal section of the thyroid. This is the transverse section of the thyroid, which I showed you earlier. And we usually document in this fashion. We measure the volume and we usually use sagittal and transverse planes for documentation. Now, what are the ultrasound features that we look into? This is just a screenshot, single screen covers everything. We look at composition, basically, whether it is cystic, predominantly cystic, if it is more than 50% cystic, predominantly solid, if it is more than 50% solid, or completely solid. Very easy to remember. And then we look at the echogenicity. As I said, is it anechoic, hyperechoic, isoechoic, hypoechoic, and very hypoechoic? So anechoic, of course, reflects the carotid artery, and hypo and very hypo are the sternocleidomastoid and darker shades of it. And the thyroid is isoechoic. Then we look at the shape. Is it horizontally wider? So we call it wider than taller. Or is it vertically wider? Then we call it taller than wider. And of course, taller than wider represents malignancy. Anything that's irregular represents malignancy. Anything that's invading and going beyond the thyroid represents malignancy. We do see the compression of surrounding tissues, which forms a peripheral halo. And usually you may or may not have a halo. If it's very thin and vascular, then it's usually benign. And if it's thick, irregular, and avascular, it's usually indicating there's infiltration of the surrounding tissues. This is a very important component, the calcification or echogenic foci, and we see very commonly ring down artifacts. So echogenic bright spot which continues downwards is called the comet tail artifact and seen in degenerative cysts. And otherwise, we see calcification around the nodule called the peripheral calcification. If it is larger than 1 millimeter, we call it macro. If it is lesser than 1 millimeter without shadowing, we call it microcalcification. And then we look at the vascular patterns, whether it's peripheral, mixed, or central. So these are the common basic things that we look for. Now, when you have peripheral vascularity, it's usually a benign nodule and you don't need to do a biopsy. If it's peripheral and intranodular both, then it's equivocal and you may need an FNA. But if it's predominantly intranodular, then definitely it is suspect and we need a biopsy. So these are the different types. That's a peripheral vascularity. Definitely don't need an FNA. This is a nodule with intense vascularity, both peripheral and central. So this is suspect and we would need a biopsy. But do remember now that with modern machines, the sensitivity of the Doppler settings is very high, and therefore we may need to set the Doppler machine to a high PRF level of somewhere around 10 to 15 megahertz, because centimeters per second, because the normal thyroid, even if it may have a background of thyroiditis and may show increased vascularity. So there are some caveats to that. Now, when we report the thyroid, we usually give the location, the size, and volume, and then we describe all the features, the composition, echogenicity, shape, margin, halo, calcifications, and vascularity. And as I said earlier, all the features which are benign are usually cystic, anechoic. They are wider, they are smooth, thin echo, halo, no calcifications or comet tail, and peripheral vascularity. And everything else is suspect for malignancy, and we shall see how it goes. A word on elastography, because this is new. Elastography basically compresses a lesion by an external force, and then the behavior of and the response of that lesion is judged with another beam that goes in, And if you see, if any tissue which is hard like steel will not be compressible, any tissue which is soft will be compressible and then regains its shape. And therefore, we say that there is a lot of strain. In this, we say there is no strain because it cannot be compressed. So that's the basic principle. And we have two types. We have strain elastography and shear wave elastography. In strain elastography, we compress or use respiratory activity to create a strain map. And in a shear wave, we pass in a pulse which measures the shear wave that is transmitted. And depending on the speed of the shear wave, a harder nodule will have higher speed and a softer nodule will have lower speed. So when we talk of speed, we call it in terms of meters per second. Anything more than 3 to 4 meters per second is hard and suspect for neoplasia. On strain, we get four different types of pattern. A nodule which is extremely soft will impart colors. It may be light blue or light green. And if it is stiff in the periphery, it will show blue color on the periphery. The classical spongioform nodule will show mixed strain or mixed strain pattern. And if it is solid, and hard malignant, it will show low strain and it will be coded as diffuse blue or red, depending on what color you like. And this is how shear wave looks. We pass in a ROI box and we get a velocity immediately, just like you measure the Hounsfield units on CT scan. So this is 2.43 meters per second. This is 1.33 meters per second. So this is soft, this is hard. And shear wave anything above 3.4. It has quite good specificity, positive predictive value, and diagnostic accuracy above 90. And you can see papillary carcinomas have shear wave more than 4. Follicular carcinomas are softer in shear wave. And different nodules will have different shear wave, and this can be pursued on the net. So coming back to ultrasound features, let's begin with the composition. Like I said, anything that looks like the carotid artery is anechoic, and therefore it's a cyst. Usually these are pseudocysts. These are due to breakdown of adenomas, and there is degeneration, necrosis, and hemorrhage, and you may get a varied appearance. It may appear completely anechoic with a thick margin here and a thin halo, as you can see here, or this is a thyroglossal cyst in the midline here. So depending on the location, and if it moves with deglutation, we call it a thyroglossal cyst. And here it may show hemorrhage, so there may be a bleed which occurs, and therefore there may be layering debris, septae formation, and clumps of echoes here, as you can see in these slides. So these they can show motion. So you move the transducer, and these particles will move. You can see that they can change in their shape, and this is typically due to hemorrhage. Now, this is a pseudo solid appearance. If there's intense amount of infection or hemorrhage, a cystic nodule can appear solid, and this is something you have to remember. Sometimes the hemorrhage may get clotted and may appear as peripheral nodules, which are usually avascular. So color Doppler becomes important. Whenever you see a solid lesion, we need to switch on color and see that they are avascular nodules. Now here is a typical colloid degeneration in an adenoma. You can see cysts with echoes, with nodules in the periphery, and the vascularity is typically peripheral. The elastography pattern, green is soft here. There is a bar which tells us the color coding, and red is hard. So the capsule is stiff, but essentially the nodule is soft. And you can also have it in black and white fashion. So white is cystic and black is hard. So the normal black hardness is seen around, and this is a cystic or typical colloid nodule. And we can then measure the shear wave speed, and it is all less than 3 meters per second. So these are all different varieties. This is again a more solid appearing thyroglossal cyst. It has got infected, and it is showing vascularity and giving a pseudo-solid appearance. So one should not mistake this as a solid nodule. Now, usually we will see multiple nodules. So these are varying types, different types. There's a complex cystic nodule. There is a nodule with peripheral cystic nodule, predominantly cystic with nodular composite, predominantly solid with cystic, But all of these did not show vascularity, and therefore they are benign nodules. Now, the classical appearance of an adenoma, a benign nodule, it will be a spongiform appearance, which will be oval in the long axis. As I told you, it's not wider than taller, very smooth margins, and these multiple small cystic areas like sponge, and it is showing high strain. Here it is, the green is the soft. There can be some coarse calcifications, and this is a typical, so the moment we see spongiform nodules, this is essentially a benign pattern. And I showed again earlier also the cystic nodule with nodular component, and here there's very little vascularity in the solid component. So this is the composition, and you can again use elastography there, so I won't go into it. Now, this is a predominantly solid nodule with cystic areas, but it is isoechoic, same echogenicity as with thyroid, and the halo is thin, and it is long axis. It is the longest diameter is in the long axis, and it contains multiple cystic components. Again, no calcification, no vascularity, suggesting that more chance of it being a benign nodule. And this is another similar kind of nodule with essentially predominantly solid. It has peripheral vascularity and some intralesional vascularity, but not too much. You can monitor these nodules over a period of time because there is some vascularity, but essentially predominantly peripheral vascularity. And the elastography also shows all the values less than 3 or around 3. So here we are in a pretty safe zone. These can be monitored over a period of time and essentially looks benign. Now, this is a worrisome nodule. It's got intense central vascularity with peripheral vascularity, and this turned out to be a papillary carcinoma. So this vascular pattern here, although the nodule looks very similar to the previous nodule, but the vascular pattern here is worrisome. The next component we look at, as I said earlier, is the echogenicity. So anything that is hyperechoic or brighter than the thyroid, or isoechoic, or has a large cystic component, it favors more a benign situation than a malignant situation. An increase in the echogenicity is proportional to the benign nature of the lesion. So you've got a thin halo here, that's the black capsule which is forming, it is getting compressed. It is oval, echogenic, and brighter with smooth margins, no risk features for malignancy. And that again is another lesion here. Elastography shows it to be soft, it is bright. It has vascularity, but essentially predominantly peripheral. And again, the color, this is the same. Their elastography can be in color or black and white. White is soft, black is hard. And here green is showing it to be hard. That's the nodule here. So very typical of a benign colloid adenoma. Sometimes you get a varied pattern of echogenicity. So it's essentially bright, but there are a lot of hypoechoic areas. And this then becomes a suspicious nodule. And you can also see that the halo is becoming slightly thick. So here we would do a FNA. If it is extremely hypoechoic and solid, then these are typical of papillary thyroid carcinomas and other carcinomas also. But you must also remember that benign nodules can sometimes be hypoechoic. And if there are no other malignant features, then they can be biopsied after reaching a certain size criteria. And we'll talk about that a little later. So typically, if you have an extremely hypoechoic nodule, it is darker than the sternocleidomastoid. It may have a little irregular margin or lobulations with intense central vascularity. Then this is what is suspect. It has a lot of vascularity you can see here, and that is suspect for a malignant thyroid nodule. And this is on elastography. You can see this is varied echo pattern, but extremely hard. Red is indicating hard, and the values are almost 7.2 meters per second, 7.8. So essentially, elastography is a very new modality. It is just a complementary modality. We rely basically on ultrasound and color Doppler and FNA if necessary. This is a complementary tool, so it yet has to come into the guidelines, but it does help us on a day-to-day basis. Looking at the halo again, like I said, if it's thin and it is vascular, normally the halo is vessels which are compressed in the periphery. This indicates a benign nodule. And again, here you can see a benign nodule. This is a very irregular, thick halo, and this is suspect, and this was a Hertel cell carcinoma here. And otherwise, if you see, it is yet an isoechoic nodule. Moving on to the next very important feature is calcification or punctate echogenicity, the samoma bodies, or what we call as microcalcification. They essentially don't shadow. They are less than about 1 millimeter or millimeter in size, and they increase the likelihood of cancer threefold. So they are essentially, and you can see here, this is a typical of papillary carcinoma, vertical, then wider, small calcifications, very irregular, lobulated, and extremely hypoechoic. And here we have given blue coding to the, you can change these color codes. So the blue indicates hard here and indicating that that's a papillary carcinoma. Very typical. That's a very smaller lesion, again showing lot of calcification and showing some vascularity, but again is a very tiny papillary carcinoma. And you can see here again the elastography is 3.8, 4.9. So we take multiple readings and then take an average, and there are enlarged lymph nodes which are extremely pathogenic. Now, looking at the benign type of calcification, as I said earlier, is the comet tail, typical echogenicity, which has ring down artifacts, so it extends downwards, and sometimes they are very tiny, and they are usually associated with cystic nodules, which are very well marginated, smooth. They may have layering debris, and this is a typical comet tail artifact calcification of a benign nodule. Now, this is calcification in the periphery, which is eggshell. If it is homogeneous and smooth, it can be benign, but it also increases the risk of malignancy, especially if there is invasion, and you can see the lesion invading through that eggshell calcification and going out. This is dense, coarse calcification. This is a pattern of calcification, which can be seen both in benign and malignant, but again, then we rely on other criteria. So if it's shadowing, it is vertically taller, etc., again indicates carcinoma, and this was a papillary thyroid carcinoma. This is an extremely hypoechoic nodule with dense coarse calcification and was a medullary thyroid carcinoma, of course, a histopathology diagnosis. So here, the different nodules, this is a mixed solid cystic lesion with coarse calcification and is a benign lesion. Extremely hypoechoic, coarse calcification, medullary thyroid carcinoma. So essentially, we look at the background features if it is in coarse calcification. Again, you don't see the nodule here, you only see coarse calcification, again, benign nodule. This has avascular halo with irregular thickening with some small samoma bodies. So again, represents malignant features. Now, what are some of the other features? So like this, very quickly, I'll go through. As I said earlier, if it is taller than wider, then it is malignant. If it has extreme nodularity or irregular margins, that is what we call as lobulations. Of course, there are other features. And this is again lobulation here. It's encroaching on beyond the thyroid margin. This is very, very important. So infiltrative lesions going beyond the margin here. Anything, it gives you an appearance. You don't even actually have to ask yourself. It tells you, it's staring at you that this is a malignant nodule. It's infiltrating. It's not smooth. And here again, multiple lesions. Now, vascular pattern, I already spoke to you about earlier. Now you can see this is a nodule here with multiple papillary carcinomas, hypoechoic, isoechoic, irregular halo, extremely vascular, and it has hard areas in the center here, as you can see here, which is hypoechoic. So wherever the elastography shows it to be extremely hard, we target our biopsies there and the yield will be better. So maybe that can be used as a guide for biopsy. Now, in Hashimoto's thyroid, in a background of thyroiditis, you may have different appearances of nodules, and different names have been given, not necessarily to describe them. It's needed, but just for characterization, you will see multiple fibrous septae here, and therefore this may appear like nodules, but actually these are normal thyroid gland, which is mimicking and showing. And if some of these are extremely hypoechoic, of course, FNAC may be required to confirm the diagnosis. An extremely bright area is called a white knight nodule in a background of Hashimoto's thyroid. Again, a benign nodule, but just to show what it looks like. This looks like the giraffe hide pattern of the skin of the giraffe. So there's multiple bright areas separated by the thick septae. But basically, we would go by the same criteria. So these are different conditions. This is a thyroid with ill-defined hypoechoic areas suggesting thyroiditis. It can be extremely vascular and it can be stiff on elastography as is seen here. And there will be areas which are very hard and areas which are soft and not so hard. And that's a nodule formation in a background of thyroiditis. So this is again thyroiditis with the nodule formation here, which is complex cystic, peripheral vascularity, looks benign, spongiform appearance, and the stiffness is in the periphery. Now, this is a very rare condition. I haven't seen one. It was given to me by my good classmate, Dr. Anil Ahuja from Hong Kong, who has done phenomenal work in thyroid. And this is diffuse sclerosing papillary thyroid carcinoma. So the whole thyroid has been infiltrated and it is extremely, it looks just like a thyroiditis pattern, but it is on biopsy and it was stiff on elastography, and in biopsy it was diffuse infiltrating papillary carcinoma. Now, there has been in the past, maybe in the 1990s, this thought that multiple thyroid nodules are benign, usually benign. It's not necessarily so. It can be benign, but we then again use the same criteria. So if you find hypoechoic nodules with calcification, then these are the nodules you will biopsy. The spongiform nodules you will not biopsy. Again, this is vertically taller. It's got peripheral eggshell calcification, very thick, irregular halo as compared to the rest of the thyroid. And so these are the nodules which you will biopsy. Here in this particular case, nothing looks suspicious, so you can go by size criteria, and we'll talk about that. There can be some caveats. This young child presented with multiple nodules, and they were appearing stiff on elastography, so we were worried, but it actually turned out to be tuberculosis involving the thyroid. So when we did an FNA, we got granulomatous involvement of the thyroid. So both multiple and solid nodules can show features of benignancy and malignancy. Now, this is the ACR thyroid criteria. Essentially, we look at all what I have just spoken to you about, and whatever, if it is cystic, spongiform, and solid or almost completely solid, we will give 2 points. So higher the stage of looking malignant, as I have described earlier, you will get 2 or more points. And if it is anechoic, smooth margins, comet tail calcification, you will have 0 points. So anything that is 0 points is thyroid 1 and it's benign, no FNA. Thyroid 2 is with 2 points, so essentially benign. Thyroid 3 will have mild suspicious features. So if it is more than 2.5 centimeter, and this is the size criteria I was talking about. So if you have 3 or more points, if it is more than 2.5, we will biopsy it. I won't go into all the details. It is available on the net as a calculator. You just put in all the features that you see, and the calculator will essentially give you the thyroid classification. And if it is less than 2.5, you will follow up. Thyroid 4 is moderately suspicious. You will then biopsy a smaller lesion also, more than 1.5 centimeters. So 4 to 6 points here, thyroid 4. And if it is more than 1 centimeter, you will follow up. And if it is, of course, thyroid 7 or more, you will biopsy. The size criteria is 1 centimeter. So anything more than 1 centimeter will be biopsy. So essentially, benign features, I've already spoken: cystic, hyperechoic, comet tail, spongy. Anything else which we have shown is malignant. And we give 0 points to benign features. Not suspicious is 2 points, 3 points, mildly suspicious, already spoke about it, thyroids 4, 4 to 6, and 7 is highly suspicious. We do look for lymph nodes around the lesion, and if they are showing intense peripheral vascularity or even sometimes calcification, then these are suspect. The hilar echo is usually lost. They can be hypoechoic, they can be globular, and then we would need to biopsy them. And this is the size criteria. I have already spoken to you earlier, and the recommendations about the same. Now, the risk of malignancy, of course, if it is thyroid 3 upwards, the risk of malignancy is high, about 5% with thyroid 3, 10% with 4, and 35% with thyroid 3. Very quickly, showing some cases, this is papillary carcinoma in a cystic nodule with calcification. That's the giveaway, and of course, central vascularity appears hard on elastography. This is the same case I showed you earlier, papillary carcinoma. This was a lesion which was showing a thin halo, looks otherwise benign, but showed very intense peripheral vascularity with some central vascularity. So we did a biopsy and actually did a removal of this lesion because biopsy was equivocal, and this turned out to be a follicular carcinoma. Now, this was a 15-year-old boy with intense vascularity in this nodule, again turned out to be a malignancy. Incidentally, we went back and we saw the elastography had shown it to be very stiff, and we decided to ignore it at that time because it was a young child but essentially turned malignant. Now, this is again a nodule which looks isoechoic but intensely hard on or stiff on elastography. So this is one area where we can upgrade our lesion. Looks benign, but on here our suspicions are high, and therefore we would do a biopsy. Very briefly, differential diagnosis. This is, of course, a lesion behind the thyroid, so it's a parathyroid adenoma. It is typical, showing the typical peripheral vascularity going inside and appears soft on elastography. So parathyroid adenomas are usually soft, less than 3 meters per second. Lymphoma with multiple lymph nodes with feathery appearance. This is an incidental isoechoic benign nodule in the thyroid, but they had multiple other lymph nodes in the body. This is a metastatic lymph node from CA pancreas close to the thyroid and the anterior to the carotid vessels can sometimes be mistaken. Again, similarly, a carotid body tumor is situated at the bifurcation of the carotid artery and looks very much like a thyroid nodule. An internal jugular vein thrombus can also look like a solid nodule arising from the surface, but on long axis, it shows it's linear and it has got thrombus with cystic areas. This is a parathyroid carcinoma invading into the thyroid, and I thank Asif for giving me this case. So sometimes lesions around the thyroid can invade into the thyroid. Here again, another parathyroid carcinoma invading into the thyroid here. So when is FNAC required? When it meets, of course, like I said, T3, T5, TRT3, TR5 with above size criteria, as I already showed you. If there are multiple nodules, 2 with the highest scores should be sampled rather than 2 which are largest. And of course, if they are similar in size, then we use the size criteria and the largest nodule will be biopsy. We also use follow-up criteria. So if there is significant increase in size, more than 20% in 2 dimensions, or 50% increase in volume, then we will do an interval biopsy. And that is easily done under ultrasound guidance. Very simple, we use a 23, 24 number needle and with a syringe attached, or sometimes even without a syringe with capillary phenomena. And very occasionally, we have to use the biopsy gun to biopsy these lesions. So that is a typical lesion which is getting biopsied here with the biopsy gun. And that's a nodule here. And that's the gun which goes in and takes a true cut biopsy and comes out. So that's a true cut biopsy. That's an FNA. That's the gun here, which shoots and takes a biopsy. More preferred for lymph nodes, and for the thyroid nodule, we essentially do an FNA for the biopsy. And here is another lesion here, which is getting an FNA done. So we avoid the vasculature and we go, and sometimes we also do therapeutic aspirations. If the cyst is very large, if it's a large thyroglossal cyst, we can do an aspiration. And in Korea, I have seen them doing RF ablation. We have not started doing that here, at least to my knowledge. We do like to draw and locate the nodules in these diagrams so that it is more useful for the consultant and especially for us on a follow-up. So I thank you for a very patient hearing, and do advocate the use of ultrasound with all its modalities for improving the clinical accuracy of your diagnosis. Thank you very much. And if there are any questions, would love to answer.